I tried to make this a little bit evidence-based, but as you can imagine, there's not a lot of good literature on this. I wanted to just give you my thoughts. What is return to sports? Is it when the patient returns to sport, which is often not truthful when they talk to the physician? Is it when the doctor clears them, the orthopedic surgeon, or is it when the physiotherapist clears them? The problem is that this is rarely included or possibly not even known. The other problem with our literature is that it's limiting because the same level of sport and activity is not reported, and as you know, they're quite mixed. The heterogeneity of the surgical procedures, I think, is most limiting because bony procedures are often mixed with soft tissue procedures, and the return to sports have large error bars as people go back to sports at different times and for different reasons. And I think the other thing we have to recognize is that patellofemoral patients are often not as active as other patients that we may deal with, such as the ACL world. So there's this continuum of the non-athletic to competitive play in patellofemoral instability. And we all do know that there is a range of activities that we go, first looking at recovering of basic joint functions, all the way up to progressive and repetitive task complexity. So I wanted to talk a little bit about specific scenarios. So we did talk quite a bit yesterday about the functional valgus knee, so in the frontal plane, but I wanted to draw your attention to something that I think is equally evident in patellofemoral instability, and that is the sagittal plane, where you have anterior knee excursion over the toes, and you can see that you're not engaging your gluteal musculature. You do not have good squat mechanics. And so these are just some examples of faulty body movement in the frontal plane. But in the sagittal plane, we do know that you can have increased patellofemoral joint stress with the knees beyond the toes, and that this has a disproportionate amount of quadricep muscle force. And these are just some examples. And in here you can also see how difficult it is to have good balance when you have this anterior knee excursion. So I think that trying to pay attention to these faulty body movements is important. Well, we all know that physical performance testing tends to be the key of return to sport in regards to timing. And there's many ways to do this. We can look at balance, coordination, we can look at muscle strength tests, and we can look at muscle endurance tests. And we have core stability, which we know is important for all athletic performance, but particularly oftentimes not present in patellofemoral patients. We have power tests and agility tests. I wanted to point out that many of our existing tests depend on limb symmetry index, and we have a lot of tests that come to us from the ACL world. These are these tests that we do for single leg hop, timed hops, etc., and they all have validation mainly in the ACL world. So for instance, the single limb hop test for distance has good ICC. We know where people should be at certain times post-op for the ACL. But when you're looking at these tests, most of them having a quantitative measurement of distance, you can see that it's more difficult to put into words the qualitative assessment, which is very important in regards to knowing if this person's ready to advance to more higher function tasks. So that limb symmetry index, even though this has been the core of return to sport, it has some problems. It's not indicative of preoperative function. We rarely have a pre-injury functional test. The qualitative asymmetries, which I just pointed out, are difficult to measure and articulate with each other, and the contralateral limb strength sometimes or often deteriorates in the rehab process. So we just must keep this in mind. And what I have felt over the years of dealing with both ACL and patellofemoral issues is that limb symmetry index is less useful as a problem, often exists in both limbs. Jumping tests not so helpful if one does not do jumping activities, and it's difficult to test core. So I just think we need to keep those in mind. And we need to also be aware of the psychological readiness. We do have some tools that help us, and I think that for the patellofemoral instability patient, which often has the fear of subluxation and that comes in everyday activities, this may be a harder thing to overcome in return to activities. Some specific scenarios. So when we look at MPFL reconstruction, we need to think about patellar and femoral fixation methods, the graft choice and strength, but as we've heard this morning, we do have good fixation methods, and generally speaking, our grafts are very strong and very stiff. Now, if you look at protocols that are in the published literature, these are protocols that are published. 53 of them did not really discuss a timeline for return to activities, but of those that did, so we had 53 that talked about it, 34% did not give a timeline, but of those that did, most of them gravitated to the 4 to 6 month range. But I wanted to pull out just a few things. If you look at these 3 studies, all of them say they may return at a pretty high percentage, but about a third to half do not go back at their same activity level. And this is something we need to keep in mind as we talk to our patients and counsel them after this is a MPF-only soft tissue procedure. When you go on to tibial tubercle osteotomy, I personally find this more troubling and more difficult to talk about. We can have tubercle fixation problems, we can have the size of the bony shingle, tibial stress risers, and whether we're doing distal alone or distal medial or medial alone. And the literature is more varied in trying to give us some guidance in this. Much of this is on the surgeon. There's a lot of surgical issues that can happen, but we have to bear in mind that we need to think about quad precautions, because we know that in an open chain activity, the lower leg is about 1/6 your body weight, and that the knee really acts as a fulcrum. We don't have too many studies trying to tell us what to do after a TTO, but we do know that at 0 degrees, there's about a 25-degree angle of pull at the patella tendon tibial tubercle site. And when you bend the knee, it is more neutral. We also know that we have pretty good load to failure if you use 2 bicortical screws well fixed, much greater than what we see with the quadricep. But the quadricep load is actually higher with single leg raising than with a long arc quad. And so I think that we often think that a straight leg raise is okay, but this may not be so good. And there's lots of issues that can happen: fractures, non-unions, fractures and non-unions, and a fracture of the tibia. And this is more difficult with distalizing the TTO because it takes longer for that posterior hinge to heal. And so when you look at the literature, there's not too much that you can say. This was one study that looked at all procedures done out of Mayo, but they did look at a pretty small cohort, but they looked more concentrated at strength. And they did have 39 knees overall, and they only looked at, but only 16 of them had a TTO. And they didn't say whether the TTO was distal or medial or both. But they all showed strength deficits at 6 months, and the strength deficits were higher in TTO patients. And when you look at the literature review, this was 23 articles. This was Bob Magnuson's very recent systematic review, Bob Magnuson and his group, and they did show that it had a high return to sport. They could not separate out whether the return to sport was different between MPFL alone or with a TTO. But if you look down below, they only had 7 patients that had a distal TTO that they talked about a return to sport, and not that many anteromedialization. And we actually had more trochleoplasties in our literature about return to sport. So I just wanted to point out that in my own patient population, I just looked at 89 patients, and 75% of them had radiographic healing by 4 months. So I think that even though many of our patients heal by 4 months, not all of them heal. And again, these were all distalizing. And so I think that for me, post-op for the TTO, you have to have careful attention to post-op rehab. I avoid open chain activities, and I do not do running or excessive pounding until the tibia completely heals at the distal shingle. Trochleoplasties, we have some evidence of what we can do. We are less concerned about return to sport because, as Dr. DeJure already said, we do have compressive forces and we have that are favorable towards healing. We do have 2 studies. One is by David's group that does say 87% return to sport, but they do not describe the level of activity. And a very recent, quite large series that was published does also have a high return to their previous sport, but they did say that the likelihood of returning to your level of sport was higher when you had a low Tegner level. So again, we have to recognize that many of our patellofemoral patients are not super active. And so again, when we look at the systematic review, overall they do very well. They go back about 93% to some sport, but not often at their level. And the range is quite broad, but it centers around 6 months. And by comparison, for an ACL, which we have much more literature on, the return to sport is 81%, and again, at the same level, is quite a bit lower. And so they're comparable. And we must remember that the reasons for returning to sport may be fear of re-injury. It could be some objective loss of function. It could be loss of interest. It could be that you've moved on with other things in life and you have increasing demands. So we need to remember this. So my conclusion, using existing literature and published outcomes studies are difficult, but we are seeing that the likelihood of returning to sport after all MPFL stabilizing procedures is quite high, but about a third of them don't return at the same level. And patients with concomitant osteotomies, primarily TTOs, take about 1 to 3 months longer and experience a higher risk in postoperative complications. And PF populations in general have lower activity levels than ACL patients. Thank you for your attention.